Okay, good afternoon, everyone. Thank you for joining us today. You are taking part in the Maryland Healthcare Commission's HIE Policy Board meeting, and we are thrilled to have you, and we'll look forward to your contribution throughout the meeting. We still have a few more people coming in, but we will start. Alana, can you take care of some of the opening remarks, please?
Yep, absolutely, David. Thanks everyone for joining us. Just a note that the meeting is being recorded this afternoon. If you do have any difficulty joining us, you can dial in over the phone. There's information in the calendar item, or it's also available on the MHCC website. If you experience any technical difficulties, you can feel free to reach out to me via email or to my colleague Kelly Scott at 410-236-0979. Her email is kelly.scott@maryland.gov. I put all of that into the chat box in case you need to pull from there. As we proceed, we ask that everyone mute their lines when they're not in use. We may mute certain lines if there's a lot of background noise, but you can always unmute yourself. We do ask that participants use the raise your hand function in Google Meet to indicate if you would like to speak. For anyone joining over the phone, we will pause from time to time and ask if there are questions or comments from people on the phone. Please do announce yourself when speaking. In the event that the meeting is breached, we do ask that participants hang up immediately. Staff will work on the back end to send a new meeting link to everyone, as well as a phone number, just to minimize disruption as much as possible. I think that's it for kind of the logistical items. David, I'll hand it back to you if you'd like to make some opening remarks at this time.
Sure, and I want to thank everyone who's participated historically and those who have participated in our most recent meeting. The regulations are a comprehensive set of 12 sections of really good, sound policy that you all helped to shape. And we're counting on the contributions of the past to be somewhat akin to the contributions of the future and really help us end up with a much better set of regulations than we have today. We appreciate everybody's time and commitment, and we'll try to make the best use of your time. We received some feedback over the last several weeks related to sections 1 through 5. We've tried to do our best to incorporate only a handful of them at this stage because there were lots to go through, and we didn't want to just rush and make changes or propose changes for discussion. So you may wonder why your changes aren't appearing in the draft document today. And they will eventually. Just give us a little bit of time because in some instances, what we found is that changes overlap, where someone might propose a change, another person may have proposed deleting a section where that change would end up. So we've got to do some mitigation of the variations, and that will take us a bit longer. Please note our executive director, Mr. Ben Steffen, who finds these meetings to be very informative, is not here today. His daughter is actually getting married this weekend, so he is away out of town, and he told me I could tell you all that. So anyway, I hope his plans out of town are going well. With that, let's just jump right into where we are. Oh, one other note. If we were in person, it would behoove us to go around the room and just sort of say who we are, create a little bit of element of acclamation to one another. We have about 43 folks on call today. It would take us way too long to do that. So we're going to opt just to publish the names in the meeting summary. And for those of you who are familiar with Google Chat, you can scroll down and see the names of the folks on the right side if that's your interest. Okay, Alana, can you take us to where we left off at the last meeting?
Yep, absolutely. So we were in section 2 at what is the new number 44 for the definition of opt-out.
And Alana, I'm going to ask if you can size it a bit larger for people who might not be able to see it. Okay. I can
go a bit larger. Just let me know if you need me to scroll or to see the comments on the side.
Okay. I think that's fine. Where you see comments on the right side and we're not, if you could just pause and then point them out so everyone gets a chance to view them, that would be great. Okay, so are we picking up, Alana, on this new 40, or are we scrolling down a bit further?
It's this here, 44 opt-out.
Is this new language? You want to sort of help people understand how it's configured with track changes and some indication of the color coding scheme?
Yep, absolutely. So on the screen, the changes in kind of that blue or teal color are edits incorporated based on our contractor, Post and Shell, their recommended suggested changes to update the regulations. As we go through, you'll see that there are also, well, I'll have to let you know when we get there, but there will be a second color appearing for edits and changes that were made, as David mentioned, from feedback from the group, especially some changes from our colleague Kim Camarada at the Office of the Attorney General. There are some comments included there, as well as some minor edits. So we'll see those when we get into Section 3.
And so to clarify, there's nothing that we as the HIE policy board need to talk about in terms of changes to 40, 41, 42, 43. It's just a numbering change, correct?
Correct.
Why don't we proceed down to 47, where we've added the words or business associate. So let's just take a moment, if everyone could glance at it and see if this makes sense. So it's the definition of a participating organization or business associate that enters into agreement with an HIE. Any questions or comments here about the addition of business associate to participating organization? And you can rate up. I see a number of hands already. So let's start with Dr. Suarez. Welcome, Dr. Suarez.
Yes, hi. First of all, can you hear me okay?
Yes, indeed.
Okay, thank you. I wanted to ask a question outside of this particular point, and that is, we sent a number of comments, by last week, which included comments on previous sections. And so my question is, how are we going to process that? That's one general question, because I think there's a number of points that were made about previous sections that we already covered, but don't want to disrupt the process or anything like that or go back. But just wanted to see, how do you see the consolidation of all those comments on previous sections before this one coming together?
Yes, Dr. Suarez, thank you for the question. So we first tried to blend it all together, and boy, was it hard to follow, because in some instances, folks were stepping on each other with changes or proposed changes. And what we stepped back and said, it's probably easier if we think of this in a sequential flow, meaning that we started out engaging everybody's help again to look at proposed changes that we engaged Post and Shell to help us with in terms of modernizing the regulations and aligning it with federal policies. And so what we've received are feedback related to the Post and Shell proposed changes. And then we received lots of feedback on what already exists in the regulation that some of the stakeholders feel should be revised. If we commingle it, we would not make much progress. So what we'd like to do is continue going forward with the changes that were proposed by Post and Shell with some other modest changes. And if it turns out that it doesn't include all the stakeholder changes, we will circle back but it's just too much to try to blend it all together at one time. We received your changes, Dr. Suarez, and many others, and we appreciate that. They won't be lost or forgotten, but in an orderly process, it seemed to make sense to continue forward, looking at it in what we might call a cleaner version at this stage.
Yeah, thank you very much, David. I appreciate that clarification, and I'm very fine with it. If I may, one comment, since we jumped from 44 to 47, but there's something on 45 that I want to make a suggestion about, which is an overarching comment as well. In 45, we reference 42 CFR Part 2, and then we also reference some federal regulation, Federal Register citation. And my sense is we really don't need to cite Federal Register elements. I think citing the regulation per se, or the regulatory citation, 42 CFR, or if it's a law, the specific law, I think makes more sense, but not citing the Federal Register per se. And I would suggest making that across the board wherever we cite Federal Register citations. Thank you.
That's a great point, Dr. Suarez. Let me just ask a couple others on the group and on the work group here what their thoughts are, and perhaps I could call on Pamela to give us her views.
Yes, I was vehemently nodding my head because I completely agree with that comment, because the 42 CFR Part 2 is likely going to get changed and supplemented again with more regulation. So it's better to just leave it at 42 CFR Part 2, which will encompass any current or future regulations that change it.
Understood. Anybody feel differently about that? Okay. Dr. Suarez, thank you very much for that comment. I see a couple other hands from a former colleague of ours here at MHCC. Welcome, Ms. Yvette. How are you today?
I'm good. Can you guys hear me?
We can. Welcome.
Awesome. So it's good to see familiar faces. This comment is on item 47, the participating organization definition, and the addition of our business associate. I think here we would suggest clarifying that it means a covered entity or its business associate, since BAs are usually working on behalf of a covered entity.
So let's read this then. Means a covered entity. And then could you restate your insertion or your proposed change just so we can type and see how it looks?
So it would say means a covered entity or its ITS business associate.
Got it. Yes. That would seem logical. Anyone have any pause about that? And because the group is so large and I'm scrolling through names quickly, I would just encourage us to keep using the raised hand feature, because then it lines everyone up on top, suppose, and I won't miss calling on you. Thank you, Angela, for that. Craig, your thoughts?
Yeah, thank you. And thanks, David and Alana, for doing this. I know it's a lot of reading that you're all doing to consolidate comments, so we appreciate it. I do agree with Angela's point there that reads better and makes more sense. I also, Post and Shell added business associate. Wonder also if we should consider adding some non-covered entities that patients may direct their data to also. I mean, I'm not sure what a term of art would be for that, but it seems like in this new world of consent, a patient might opt for a community-based organization that does meal delivery to know if they've been in the hospital. And so it would be nice to have those people in a more structured participation agreement as well.
So, yeah, I sort of see that. What do others think of doing this? Because, and on the one hand, I go, it fits. I could see that. And the other hand, I go, it feels like an anomaly to include it. But I don't have any opinion. I think we want to figure out, does it fit, or does it fit here, or does it belong somewhere else? Perhaps, Dr. Lewis, you might share with us your thoughts. and you could be muted, or perhaps you stepped away. So let me ask Catherine to share with us her thoughts.
Hello, David. Happy to do so. I actually think that makes a lot of sense. And I think I might have a quick question back at Craig, maybe to give it a little more context. You gave a good example, but why would you want that meal delivery service, for example, to be a participating organization?
Good point.
Yeah, no, thanks for the question. So I think as we work through, these groups with whom we're pushing referrals and potentially clinical information, by having them bound under consistent agreement that all the other organizations are signing, that gives us a standard way to process them and work with them. I think it just helps. It's consistent. It passes the same rules to everybody. Signing individual data use agreements or kind of coming up with scratch for each time we do this is becoming somewhat problematic.
Yeah, I agree. I think consistency will add a lot of value and a lot of clarity to what's expected as well.
Yeah, okay. That works. If there's not anyone else, we'll put it in there and we'll move on. So Alana, just I think you do have a question. Kim.
Yeah, and I'll say what I said at the last meeting. We're looking at this in a vacuum in the definitional section, and I wouldn't be comfortable saying I agree or disagree with Craig's suggestion until I see it being used within the rest of the regulatory scheme.
Yeah.
So I'm not saying, I mean, it makes sense conceptually, but without seeing how that term is used throughout these regs, I'm not comfortable saying I would agree with it or not.
Yeah, and I that's an excellent point to make. And I think that works. We should just sort of note that to ourselves for any of the proposed changes we're making at this stage in the document. It doesn't mean affirmation by the HIE policy board. It just means that we've made the change here, and greater review will occur as we go further through the process. And it will occur by lots of people, including yourselves, if that's an interest of yours as well. But thank you for noting that, Kim. And I think Dr. Suarez has his hand raised at this point.
Yeah, just a very quick point, because I do agree with Craig. I think participating organization should be any entity that enters into an agreement with an HIE that governs the terms and conditions. Because why selectively exclude or include certain entities that are defined as participating organizations? There could be many other organizations that are participating in the HIE, including, as Craig mentioned, CBOs, community-based organizations, but also third-party data aggregators or you can imagine of many other entities that are not covered entities or business associates of a covered entity. So why define participating organization as exclusively covered entities or its business associates, and rather any entity that enters into the agreement?
Yeah, and there's folks in the chat that are agreeing. Leah, we also saw from Clay, and I think Pamela and Angela also agree. So we'll add this to the comments section and again come back to it. And Alana, just keep in mind, there you go. You got to scroll a little bit. Perfect. Thank you. Let's go down a bit further and see where we get to. Clay, you have a comment? Welcome. And I think you're muted if you're trying to speak. Okay. We see your hand, Clay, and we'll just come back to you, or if you can unmute, you can jump in, that would be great. Okay, so the next one we have is the new 48. So we move from medical record to health record. I think not too many folks would disagree. Health is more broadly used than medical, and it certainly includes the behavioral health community if we go to health. Alana, please scroll. Okay, so we have some count changes. And then under person of interest, leave a similar change to health from medical. Okay, let's go down a little further. Again, we see medical being changed in a couple places. Point of transmission, let's look at that. So we move from entity to person. Let's just make sure that we're on the right path here.
David, can I ask why we changed that to person as opposed to leaving it an entity?
So I couldn't tell you that at this stage, and I simply can't tell you. I'd have to go back and dig through and find out, because lots of changes were made, as you see, and I don't have the background handy on all the changes. Is there something?
My only concern with that is that I think with a lot of point-to-point transmission, you end up sending data to like a pool of people. You know, Dr. Smith may be on vacation, so Dr. Jones is in the pool to get those point-to-point transmissions. I think by limiting it to a single person, you're really narrowing kind of the definition of point-to-point, when I think in practicality, point-to-point is used from entity to entity versus single person to single person.
So that's an interesting concept, because I think it actually could be both. So what do you have any?
Oh, person is a defined term. That's a good point. Where is that? Can we scroll up to person? Sorry, thank you. There you go. Person that works for me. Thank you, Cindy.
Okay, let's go on down. Dr. Suarez.
Yes, sorry. One quick point about medical record, health record. I totally agree. Health record should be the term. I think it would be helpful to define health records. I couldn't find the definition of health record on the proposed regulation, nor medical record for that matter. But it's also interesting that Maryland has a Maryland Medical Record Act. So they refer to as medical record. But I do agree health record makes a lot of sense. But I suggest defining it, and hopefully defining it by referencing the definition of health record on federal regulations, just to be very clear what health record means.
Okay, we'll add that in. And I think you're referencing the Medical Records Confidentiality Act. And that goes back a long way in Maryland. I don't remember the date, but I feel like that's probably 20 years almost.
Yeah, exactly. And there is one place where medical record still is without change, without being changed. If we are changed, I noticed that you change medical record across the board. I think you missed one, just to make a quick note. It's on page, it's number 17. Item number 17 on page 6, I think.
Okay.
There's one medical record that is still says medical record instead of health record. Just
let us just highlight that for the moment.
Oh, well, I guess in this version it is. Sorry. I didn't. I apologize. Sorry.
Okay. We'll continue on. Okay, we've covered the okay. So let's look at number 53, the definition of population care management. Any thoughts here or concerns? And good afternoon, Robin. Thank you for joining us.
Good afternoon. So I had a question here that I submitted in my written comments, and that is just, is there a state or federal definition that this can be tied to?
We can check. I don't know, but that is notable, and we'll add that to our to-do list.
And it's just looking at it from a consumer standpoint and just thinking through how much actually can fall under this bucket. If there is a way to sort of be very consistent with how the state or the federal government is using this term, I think it might be helpful.
Yeah, I don't know. We will take a look at that to see
Okay.
if there's opportunity to align.
Thank you.
Thanks, Rob. Good afternoon, Adrian. The floor is yours.
So I was just going to take a stab at answering Robin's question, because for my fellow old timers from this committee, you may remember that I don't think that there is another definition. I think this was a definition that we crafted because to specifically address some of the population health type reporting that HSCRC under the new all payer model were requesting, and there was a concern from patient advocates that there be some parameters drawn around those use cases. And so I would be surprised if you found a definition anywhere, but this is one I do think it would be good to discuss. David, I heard you say earlier that we want to stick with the post and shell changes in this as part of this conversation. So I do think that when this was initially drafted way back, population health and population care management was not the same level and at the same request as it currently is. And so it would be good if there is something we could look to align, more aligned with HIPAA and not what we're doing here. That would actually be, I think, an improvement for transparency, for patient understanding, as well as from an HIE's perspective to be able to understand what is allowed under public health, what's allowed under population health. This is currently allowed under HIPAA, under healthcare operations. And this, along with, I think we're going to get to definition 55 in a second about primary use. By narrowing some of the definitions and not aligning with HIPAA, we are somewhat putting the HIEs at disadvantage for things like TEFCA and things like other types of data sharing that are permitted under HIPAA and are being pushed from federal agencies and other agencies. So it might behoove us to put a pin in this and have this conversation more broadly once we get through the post and shell edits.
Yeah, okay, that does bring to light a very good point. Thank you. We will let's resurface that in a few moments. Appreciate the input. Any other comments here? Okay, let's scroll down. So we have the population care management. Reactions? Okay. Adrian, your thoughts on that? I wouldn't mind getting your thinking on it. If you want to scroll back up a little, Alana.
Same thing.
On 54, Adrian.
Yeah. So I think, I just maybe would reiterate what I just stated. I think it's having a more clear definition that aligns with something in HIPAA would be an improvement, as opposed to from a patient transparency perspective and from an understanding of an HIE perspective of what is population care management as it differs under healthcare operations under HIPAA.
Yeah, so that's interesting. We either go higher level or more detail. And I think what you're saying, there was a time when we needed to have that much detail, but as the what we would call boots on the ground environments evolve, having too much specificity is not a good thing, I think is what I hear you saying.
Or we either need more specificity or less specificity. We either need to, I would argue, you need to align with HIPAA and allow more operations as currently allowed by HIPAA, or you need to make sure that we're defining things like risk assessment, right? So risk assessment as it relates to a government entity trying to risk assess for a population of patients that it has under its control, or risk assessment from a treating provider who has a treatment relationship with those patients. Is that considered population care management, or can that fall under, treatment under HIPAA? And I think it becomes really tricky when we have some specificity without aligning it with a federal law, or being even more specific about what exceptions might apply.
We could be more just use air quotes, stringent than the federal law too, right?
Yeah, of course.
Yeah. So, I don't know. I'd like to hear what some other folks think. Dr. Suarez, your reaction. Adrian brings to light some good points.
Yeah, thank you. Well, the first comment I have is actually, and in the spirit of what we just made us change from medical record to health record, I think that the term that is used more widely and consistently, even in Medicare and CMS and other programs, NCQA and other programs, is population health management. And population health management really encompasses all these elements that are being mentioned here about processing for improving clinical outcomes of a defined population and all this. So my suggestion to start with would be to switch to population health management rather than population care management. I think the other comments, I'm fine with the perspective that were brought up by others on the term. So I don't think I have any other comments aside from the title itself, because I think it's more comprehensive and more consistent with what we've been doing. Thank you.
And we see it more frequently used, I think, to your point, when we say population health as opposed to population care. Let's see, Mike Dennison, I see you're on the call. Thank you for joining us. Good afternoon. Be interested in your thoughts here.
Well, I guess I'll go back to the commenter that mentioned that it is allowed under HIPAA as far as operations. So it would be, we need to make sure that it aligns with HIPAA so that it is not contrary to. And I think the definition here, aligns with that, but we might want to check.
Okay. Anyone else have comments? I don't think I see any hands up. So we have a takeaway to look more closely at this. Okay. Alana, we can scroll on down a little bit. So Craig, your thoughts here?
I won't belabor the point too much, but I think my comment on 55, probably 55E, it looks like we're being more restrictive than the citation there by saying that HIPAA, that we're limiting this to quality assessment and improvement activities and not including care coordination. And I just wonder why we want to be, are we deliberately being more restrictive than HIPAA? Or are we comfortable aligning it with HIPAA so that we can add care coordination back in?
Yeah, this is one of the original points that were elements of the regulation. I think you're saying at this stage, probably looking at this from a different angle would be helpful. I would invite Kim to offer her thoughts here.
Yeah, David, I'm actually just taking in what people are saying and what we're doing, because I have to look at it in total. So, why it was defined this way for a reason. I'd have to go back and look at the section on how we use population care management. I'd have to review those sections to even remind myself why we did what we did.
Yeah, it takes us back many years. That's exactly right. It takes us back many years. I hate to say we have some long timers here, but if anyone else who's been around for a while has any thoughts, you guys know who you are. Feel free to speak up. I think Pamela and then Angela.
So I'm one of the long timers, and I think the idea originally was to sort of take it slow because, HIEs were due and CRISP was kind of scary. We didn't know what was going to happen. And I think there's been so much push at the state level, at the federal level to really move in a care coordination manner that I really think it's time to sort of potentially modernize these regulations to include things like care coordination as a primary use. That's just my personal opinion.
Good point. And I think, Angela, you had your hand up. Are you wanting to make a comment? I don't see it now, but maybe.
Well, I think Pamela summarized it best. I think she has a good historical context. The idea was that we weren't ready to open it up all of healthcare operations at that time, and things have changed.
Great memory, but you were one of the original group, so thank you for that feedback. Dr. Suarez, and by the way, I think Clay is agreeing with the narrative so far from Pamela and from Angela. Dr. Suarez.
Yeah, I wanted to make similar comments. I just support it. Well, first of all, I think there's still some confusing misalignment between the definition of primary uses versus secondary uses. I think that needs to be tightened up a little more. And we made some more specific suggestions on our written comments. One thing that has been noted is in the healthcare operations, certainly population health management or population care management, however we want to call it, is included as part of healthcare operations. And so my suggestion in the E, healthcare operations, if we're going to retain it the way it is, or somewhat modified, is included but not limited to, in the second line, where it says including outcomes, evaluation, and development of clinical guidelines, and all this. I think we need to be mindful that in order to list every possible healthcare operations, we would be, well, referencing 42 CFR or 45 CFR 164.501. But if we're establishing some inclusions in the statement, I think then we need to state that not limited to, or simply not define it as including outcomes, evaluation, and development of clinical guidelines, because that in general is part of healthcare operations and is considered under 45 CFR 164.
Okay, so Alana, do you have all that from what Dr. Suarez was suggesting? And I think Mike, can I bring you back to the forefront? I saw a comment and it just got by me. So can I get you to make your point here?
I guess I was just agreeing with everyone else, and I was including also case management as part of care coordination.
Very good point. Very good point. Okay. We will continue onward. Any concerns about the addition? This is just mostly cleanup here. Meets the member composition as opposed to shall meet. So this is a suggestion at the end. So Clay, are you able to weigh in? I'm not sure I understand your comment.
So I was wondering if from Dr. Suarez that was his suggestion that we simply end E after the reference to 45 CFR 164.501, so that rather than try and articulate parts of HIPAA, just saying that it really is just HIPAA.
Right. I think that's what Dr. Suarez, I won't speak on your behalf, but I think that's what I heard you saying.
Yes, exactly. Thank you. Thank you for that. I appreciate it. Yes, that's what I was suggesting too.
And I would be in support of that.
Okay. Thank you, Clay. Glad you were able to participate today, and it's nice to hear you again. So we captured that. Let's go on a little bit further. We looked at, so we're now back to health versus medical, and we've captured some notes about its use. So we'll be consistent here. We'll go back and look at that. And we've done some numbering realignment, and then our next change shows up in 62. and the definition research. Thoughts here, folks? So we've struck out a little bit of the narrative. Dr. Suarez?
Yes, I'm sorry, I was catching up, and sorry to take you back to 57, but very quickly.
PHI?
Yeah, PHI. I think in general, what we're trying to cover here is electronic health information, which encompasses anything, including PHI, including health records as defined in the general article. And so here, one suggestion is to consider really using the new concept of electronic health information, which is what information blocking in this ONC rules are calling for, CMS is calling for, which again includes protected health information, includes any information, really health information that is in electronic form, which encompasses everything, including sensitive health information, of course. So that's just one quick suggestion about that, rather than trying to expand the protected health information definition under HIPAA with these additional elements. Otherwise, entities that are working in states beyond Maryland are going to have to think of, is PHI as defined in Maryland, which includes PHI plus other things, or is PHI as defined in Colorado, which is HIPAA PHI. So I think that simplified by using EHI, electronic health information, it simplifies the scope. It encompasses everything as is intended, I think, in the HIE regulation here, and it avoids this additions to PHI, which is a very defined HIPAA term that if we mix it up or extend it or amplify it, it will create more confusion.
Yeah, I see heads nodding. So that with I think everyone's or at least a lot of folks are in agreement. So good catch. Thank you very much.
Thank you.
Let's go down a little bit. Oh, Angela, your thoughts.
Yeah, I was just looking at the reference to Health General, and I think that it references J, which is mental health services. Am I reading that wrong?
So so scroll down. So you mean 57? Scroll down a little bit, Lana, please.
Is it J or I? Sorry.
Okay, so under what term? Because unless Alana, I'm lost a little bit trying to keep up visually.
Yeah, right there, Alana, you have it. Is that J or I that we?
Oh, that's a J.
It should be I. I is the medical record. J, I think, unless I have my reference wrong. J is mental health services.
Okay, yeah, we'll
I just double check.
Yeah, thank you, Angela. Appreciate that. Angela has a great eye for details. I learned that working with, having had the privilege to work with her for so many years. Okay, let's go on a bit further. Okay, now we're at research, so we'll come back to where we were. So we've actually are taking elements out of the definition. Anyone have pause about that? And just as a reminder, you're looking at these track changes. There, and I think it goes back to Kim's point early on. Just because something is added or proposed to be deleted doesn't mean that we end up there. It's just a place to start because there's lots more reviews and a lot more research behind the scenes that still needs to occur. Your feedback is very important to us because if you don't feel something is appropriate or it needs to be added or vice versa, struck, it gives us something to take a hard look at more than we might have had you not shared your thoughts. Mike, your thoughts?
Well, I'm guessing, do we need the words "for systematic investigation"? Could they also be struck so that it basically reads through an HIE as defined in?
That's a good point. We will note that here. I think it would seem that taking that out would make sense.
Because it seems limiting or constrained.
Mm-hmm.
Then you'd have to define what systematic investigation means.
Mm-hmm. Okay. Angela, I saw a chat message. Is that something is that taking us to another section, or?
Nope, I don't want to disrupt the conversation. Just a note to Alana.
Okay, very good. All right, thank you. We'll go on to 63. So this is an addition, retrievable storage medium. Any concerns about that definition? In the addition of that term? Clay, your thoughts?
I'm just wondering what the word retrievable adds to that.
That's a good point. Let's retrievable versus storage medium. Mm-hmm. Mm-hmm. I think I get that. So we'll note it here. I think that's a good point. Dr. Suarez.
Yeah, just a quick note on the previous one, again, very quickly. I think limited data set is not defined in this regulation. De-identify information, I think it is, but limited data set is not. And so I think this is one place where it's used, and it would be helpful to define it consistent with the HIPAA legislation or regulation that define it. So that's just a quick suggestion there.
Understood. Will do. Thank you. Let's go down. Mike.
Just a comment. I think limited data sets is defined in those statutes referenced above, or those regulations referenced above.
Okay. Let's make a note, Alana.
Yeah, both de-identified data and limited data set are defined in those statutes. So then he called the question of why including the use of de-identified if it's already cited in the statute.
Mm-hmm. Good point. Okay, we'll note this and look at it. Okay, traveling along. Pamela.
So just a note here for, 64, depending on where we land on care management and healthcare operations for primary use, we would need to make corresponding changes here that it's a primary use, not a secondary use.
Right. So, but would we still call it care management? I feel like that we're missing something there. Pamela, would it still remain as care management? I'm not
I think it's, I can't remember what we had above, but case management and care coordination is usually what you see as case management, care coordination. I think they usually go together. So
that's a good point. That answers my question. Thank you. Okay, let's go on down and Dr. Suarez.
Yes, I mean, I think it's important to know care management is an integral part of treatment. So considering secondary use of data might not be necessarily consistent with the use of data for care management, since it's truly a treatment element. So I don't know why we would want to say that care management is secondary use of data.
I think it gets back to when we think of distinctions between primary and secondary care. I mean, you always think of clinical data in primary care, but I think that if I remember the historical approach here was that there needed to be some shaping of what non-primary care data looked like, you know, what that might mean. And Pam, your thoughts?
I was just going to say the other issue is that, so under HIPAA, care management by plans is actually healthcare operations, not part of treatment. And I think that that was the idea, is to the extent payers were going to be using HIE data, it would be a secondary use versus a provider. But I'm still in support of moving all healthcare operations to a primary use. That's still what, but I think that is why this existed the way it did historically.
Thanks, Pamela, for that reference, because I think improving patient safety is another one of those elements related to healthcare operations.
Yep. I agree. I would move that to yes, I agree.
All of primary care would include all of healthcare operations. I think Pam, you just said, is that correct? Yeah. So let's make sure we note that alone. And that's a change in the primary care definition to bring all of healthcare operations up under. Okay. And Alana has very quick fingers. It's a tough job to scroll back and forth through all this. Okay, great input. Thank you all. So let's look at sensitive health information. And here again, we've removed a section of it. Your thoughts, anyone, on that deletion, proposed deletion? And so Catherine, your comments.
And I'm sorry, David, I'm going to take you back up to the previous one as well. Back to our examples. You know, now that we're kind of cleaning up and putting some more clarity in above, you know, in this bullet, I'm wondering why we are actually listing examples. That's a little bit of a departure from some of our guiding principles, right, on how we have done this work in the past. Is there a strong reason to include some examples there?
Probably 10 years ago, but
I feel like it's a leftover too. I feel like it's an historical leftover when we're trying to put some specificity into it that now could probably be struck.
Yeah. Okay, good point. So let's go back to sensitive health information. Matt, do you have any thoughts about that? What you see here under sensitive health information? And you may be muted or stepped away. Okay. I do not. So Matt's saying it looks good in his view. Dr. Suarez.
Yes, I think under B, the last part that says under Public Health Service Act 42 US, I think that's redundant with A.
Yeah, that's a good point. Any reactions from others? Okay, we'll note that. That's a good point. Traveling along a little bit. Okay, so we have an addition of the 21st Century Cures Act. Anyone have any thoughts here around the additional language? Okay. We will, Dr. Suarez.
Not about this one, but about the next one, 71. We found out in the analysis of the document that unusual finding is not used anywhere in this regulation. So I don't think we need that.
Yeah, we're not using it anywhere. Would we? Yeah, I don't suppose we would need it. I mean, that's a good point. Not sure why we added it, actually. That's going back a ways. So, okay, good point. Thank you. Okay, going on to section 03, rights of a healthcare consumer concerning information access, used, or disclosed through an HIE. So now we get a little more into the meat of this. So A talks about the rights of the healthcare consumer. And the first one, the right to have information regarding the healthcare consumer's rights under the regulations, readily available, and now we've added and easily accessible. So I wonder if there are questions or comments about that addition of and easily accessible. Good afternoon again, Robin. Thank you for weighing in here.
Yeah. So one of the things that has come up with other consumer information, making sure it's accessible, is just clarifying that it is available at all points in time and not just by request. And so sometimes it's just a small wording change to make that clear. Certainly having on a website, hopefully that is easily identifiable in a search engine or findable is would be preferable as well.
Okay. Okay. Rob noted that if we take it out here, we would also need to change our application for registered HIEs. That's a good point. Dr. Suarez, your thoughts? Thank you, Robin.
Yeah, no, I agree with that, and I wanted to also add on this line number 1, if we are going to switch to or 1A, I'd say, if we're saying patient PHI, and we're switching PHI to electronic health information, I think it will be more encompassing again. If we go up in the definition of PHI and we change it to EHI, that encompasses PHI and all that. And then in this place and probably every place where we reference PHI, we should reference EHI. And it makes a lot of sense now that I read this, because it's, you know, the accessibility of a patient's electronic health information through an HIE. So electronic health information is a much broader concept that includes PHI. So just a note that if we agree to change PHI or protected health information in the definition and call it EHI, then that will have an impact in these other places where we reference as PHI.
So I have a thank you, Dr. Suarez, but I have a question, and I'm picking on readily available and easily accessible. How does this get interpreted? I'm just trying to think of if I were an HIE, if I were CRISP or or AI, I would be saying, how does this get interpreted?
Well, I think readily available. Sorry.
I think, okay, go ahead, Dr. Suarez. I think then Dr. Lewis was going to make a comment, but please proceed.
I'm sorry. I just, yeah, readily available and easily accessible are both, I mean, generally industry terms, and also they're referenced in places like ONC information blocking or CMS interoperability rules. My own sense is, you know, readily accessible means that it's or readily available means basically that there's nothing that you know that imposes any blocking on the accessibility of the availability of the information. and people have it available when it's needed and for the purpose that is needed. And easily accessible to me means more, the technology that is used allows it to be accessible in a simple way. For example, using APIs and FHIR rather than using more complex electronic documents. So those are, to me, elements that I think can be referenced in CMS and ONC other regulations.
Okay. Thank you, Dr. Schwartz. Pam, does this seem sound, and what Dr. Schwartz was noting seem sound, or do you think that we need to do more around defining these kinds of terms?
I mean, I personally think they're very vague and open to interpretation. I mean, I think that's just the way they are. I appreciate the context and the concept, and we want to make this material readily available and easily accessible. But to your point, I don't know what that means. And when you talk about accessibility, then are you talking about it has to be translated into 7 different languages? And does it have to be in, large font? And accessible sometimes has a very heavy kind of generic meaning to it. So I just want to make sure we are all in agreement with what we really need.
I think we have to come back to this, now I missed some of the comments. So I don't know if Clay or Angela, the comments going back and forth, are they in support of, or meaning the questions that we're raising, or something else? Can either of you weigh in?
Yeah, I think Clay and I were just having a trip down memory lane, but I think it was more on the unusual findings, historical context, but no worries there. As it relates to the readily available and easily accessible, I think you're right, those terms are a bit vague, but I think later provisions of the regulation specifies how an HIE must make information available to healthcare consumers. So maybe we should wait to make a decision until we get to that section.
Understood. And I think Kim noted that the unusual findings is used elsewhere. So Alana, if you could just make a note that we want to check that out. We will want to take it out just yet. Let's just do another scan. I think Kim pointed out where it is in the document. Okay. Thank you all. Good conversation. Clay, go ahead, please.
Would it make sense to say that it is consistent with current laws and general industry practices, so that it's not as vague and open-ended?
Right. That's an interesting point. I think we can capture it, and we'll come back to that, because you're saying let's give it some structure, and have it a bit more pointed to something, if you will, as opposed to the wide open range of interpretation it could mean.
Right.
That's a good point. And I think we run into the same sort of concept in a couple other places, but we'll go back and look at, I think Robin brought to light in one of the chats I saw quickly. So we'll come back to that. And we've heard Dr. Suarez talk a little bit about the notion of EPHI versus PHI that's shown in A. And some of the folks seem to be in agreement.
It's actually EHI versus PHI, not EPHI, but EHI. EHI is the more encompassing concept.
Gotcha. That's true. That's right. Good point. Thank you for the correction. Okay. And I think Robin noted the term others. So Robin, I believe that captured it. Where we have the addition, we want to just note that as well. Okay. Let's go on down a little bit. Clay, is there still a comment you would like to make, or is that a holdover?
No, sorry, that's a holdover. Sorry about that.
No worries. So we've added the word point-to-point and the word transmission. I think that was probably more of an omission than changing the content or the meaning here. Under C, we've now added some timeframes around that. A healthcare consumer shall be advised in writing by the HIE, receiving the opt-out notice or request within 10 business days of the HIE's receipt. Reactions, comments? Craig, can I call on you for that?
Of course. Yeah, I mean, we were kind of debating, is that too aggressive? Is that fair? But I think that probably strikes an appropriate balance between giving us space to work, but also, you know, being responsible and quick to reply. So we don't have a problem with that.
Okay. Rob, your thoughts, since I know you're here on the call today?
Yeah. Hi, David. I mean, I don't really have a strong opinion. Like we you know, HIEs need to be able to support opting out in general. And so how it's, you know, this definition works for me. I think it's important that HIEs support that workflow, though. That's important.
So I have a question then for you gentlemen of HIEs. So do we need to have some sort of contexting here, because it says communication shall be advised in writing, but we don't really say what writing means. I mean, yes, one could argue that it's pretty much presumed, but there are some that think of writing today could be a text message, and others that would say it's a formal letter. Are we okay with the way it appears here, or do we think it needs some additional structure? And because we have this in a couple places in regulation.
Go ahead, Craig.
Well, yeah, I was probably and I'm going to echo Kim a little bit. Yeah, there's a later section that talks a lot about how you're communicating with consumers and written versus electronic and timely. And so I agree, we need to address it somewhere. And so if perhaps this was just, you know, the healthcare consumers shall be advised by the HIE, then we can address the kind of the most appropriate and best methods to advise people later. And we should be consistent between sections.
Right. Rob, your thoughts you were going to make?
Yeah, exactly what Craig said.
There needs to be some alignment. It's just exactly where it appears. I mean, is I think, or consistency in how it's structured throughout. Kim, could I call on you to make a comment about the whole notion of in writing? What does this mean? You know, some HIEs are going to say, "I'm confused."
Yeah, no, I agree in concept with. I mean, my initial instinct, again, without looking at everything globally, is usually it's sort of you're communicating for the most part with the consumer in the manner in which they wish to be communicated with, right? So what's their communication election method? Having said that, there are instances when the consumer may well have elected electronic communications, whether that's text message, email, portal, whatever it is. But there are some notifications that are so important that they should be sent in first-class mail, nevertheless, and this may not be one of them, but I do think we have to keep that in mind. So, yeah, do we define how, you know, what in writing means or that communication? I think we should definitely look at that globally. I agree.
Good point. Adrian, your thoughts?
Yeah, I was just going to agree with Kim that from a patient perspective, we actually advise patients before they ever opt out that this is what's going to happen, right? So it's not just from a patient perspective, you don't want to really wait until after they've decided to opt out. You want to provide them this information so as they're making a decision about opting out, they have all the information that they need. And we provide other ways for patients to opt out. And so we should communicate with them in the way that they are communicating their opt out, rather than they communicate their opt-out electronically and we have to send them a notice, right? Or they communicate an opt-out via phone and we don't tell them on the phone that what this means, and then we send them something later on. So I totally agree with Kim that it makes more sense to be a little bit broad here so that it can be in whatever manner that the consumer chooses, right? And that it meets that it's appropriate for the time. You don't want to wait until after 10 days after they've opted out to tell them that this is what's actually going to happen, because more questions will just arise.
Yeah, that's a good point. And it gets a little more tricky when we get to the other section. We'll just have to keep this in mind, because if it's a manner that the consumer in a manner that's consistent with what the consumer's preference might be, even that could be a bridge too far in some situations. So I don't know, but I think we want to think about that as we, or how we put some realistic boundaries. And I could be overthinking it, but just keep this in mind, and I'm sure we're going to dig into it a bit more. Pamela, are you going to tell me I'm overthinking this?
No, I just think I'm thinking we're overthinking this whole section. I mean, I guess to Adrian's point, which I think is a really good one, we have it in the notice, you know, like our notice of privacy practices says this, like if you opt out, this still, you know, doesn't preclude any participating organization from keeping the PHI. So it does seem nonsensical to notify them 10 days after they've opted out that this happens. It feels like rather than advising them in writing after they've opted out or concurrently with their opt-out, it should be in the notice informing them of the HIE in the first place. And so I don't know if this should actually be, I've always interpreted this as just you have to advise them in writing, meaning the notice of privacy practices is sufficient. I never interpreted this as you have to give them a notice, like a separate like response to their opt-out. But if
this,
so,
yeah. The history on this was definitely, I mean, I remember the policy board having lots of conversation a long time ago about this, but I can see how you might interpret it that way. And perhaps that's the way we should structure it. Let's see, Kim, your thoughts, Kimberly, your thoughts.
Yeah, no, and I recall the initial notice of privacy practices that we all know nobody really reads. Like, I don't think that's an adequate notice here. I do agree though, as someone is opting out, whether they're doing that, they're filling out a form, and I don't know how this works in practice, right? If they're opting out of CRISP, you know, when they're doing that, it should pop up and say, you should know that by opting out, anyone that has your records already has your records already, right? So, I mean, it should be contemporaneous. If you're opting out electronically, it should be contemporaneous with that. I mean, that makes sense, right? If you're opting out by mailing in a letter, then that letter should come back to you saying, hey, you know, we got your opt out, you should know, right? I mean, I think it is a little more, it could be a little more specific depending on how someone's opting out. But the initial notice about the notice of privacy practices at the beginning, I don't think is adequate. Yeah, well, Dr. Suarez just noted that it's really a rhetorical question of some sort, and that is, do HIEs provide notice of privacy practices to consumers? And maybe we could get the HIEs to weigh in. The participating organizations do, yes.
Yeah, I know the participating organizations do. I'm just wondering if we're talking about notices in this statement in this section C or subsection C that is related to HIEs. I don't know how the HIE notifies or provides a notice to the consumer. I don't think it's a notice of privacy practice.
So well, that's when I think back historically, that's correct. But I think what Pamela might be pointing out, and I don't mean to put words in your mouth, so correct me if I'm wrong, is that it passes through. So you know, if they opt out at the provider site level, that's shared with the HIE, and then this is really to some extent a confirmation or an affirmation that the opt out has been processed. Is that, Pamela, am I misstating or stating that correctly?
No, you're right. I mean, I see Dr. Suarez's point. I mean, technically the HIE is not the one providing the writing, but I think the idea is that our participating agreements require that the providers provide notice of this. And I think, you know, Kim, I agree with your point, but I will say that there's a way the patient knows to call or to opt out, and usually the way they find out to opt out is through some notice. So I do think you can make the notice still in where the opt-out information is, you know, so if it's not the NPP, I agree, nobody reads it, but if it's in your just general materials about HIEs and how to opt out, I think that's still sufficient, because someone doesn't know to opt out if they don't know the HIE exists.
Rob, that's an interesting point. How does AI make consumers aware? How is it made aware? Notice, how does this get how does it get to the consumers through AI or vice versa?
It really varies, David, because I mean, we we operate with network partners like CRISP in a lot of states, and we just adhere to whatever policies they have. So, you know, so if a patient opts out of CRISP, as an example, you know, CRISP is going to store that at their MPI level, and what that means is that the systems that we support will not generate notifications for those patients to providers. So we're not the ones setting the policy, David. We're always adhering to whatever our network partner's preference is, or whatever the state laws say needs to be done.
Okay, good point. Thank you very much for the clarification. All right, so Dr. Suarez, we'll give you the next word or final word on it.
Yeah, thank you. Not to overly wordsmith this, but I mean, in my mind, the consumer, the patient, can come to the provider, which would be the participant organization, and say, I opt out from participating in an HIE, in this HIE or whatever. And so the provider is the one that receives that. But in other cases, you know, of course, the patient can go to the HIE directly, the consumer, and say, I want to opt out from, and that is what this statement under C is about. If the patient, the consumer, informs the HIE, then the HIE has 10 business days to inform about the fact that the opting out does not preclude the participating organization. So I'm trying to reconcile the two, because if it comes to the provider acknowledges the opt out and you know, stops communicating that information via the HIE. But if it comes to the HIE, the provider doesn't know that the patient has opted out and might continue to use the HIE.
So I think you bring to light, you know, when I think historically what it means and how it's being interpreted today, there's variation. But I think both points are very good. So we're going to note it, and we're going to come back to it. Even sometimes the most simplest, what might seem to be simple changes there, when you start thinking about them in the policy arena and practicality of implementation, it becomes much more complex. So these are very good points to bring up. And thank you all for that. Lana, we can travel on once you finish making that note. Okay. So the next one is an HIE shall make, and then we've taken out good faith effort. We'll say an HIE shall facilitate a healthcare consumer's amendment of their PHI. So I wonder about this one, and it's here and we've struck it, but I'm very interested in what folks might, you know, think about this, because the whole notion of good faith means I tried, but I couldn't reach person, or there was something else that, you know, we just couldn't, it was beyond our control to, when we, with the removal of this phraseology, it sort of suggests that the HIE is simply must do it. And perhaps you all can tell me if I'm right or wrong in my interpretation, and whether this is something that makes sense to you. And Catherine, I'm going to pull you out to see if you would weigh in here.
Yeah, you know, can we hold an NHA accountable to facilitate, you know, definition of facilitate there. You know, I think the history and the, you know, good faith effort was exactly to that end. We can provide information, we can share, we can attempt to facilitate to that end, but how do we hold them accountable to actually seek that, you know, amendment to completion? You can't, of course, providers. I bet you Dr. Lewis has something to say about this one as well if he's on today.
I know he's on, but I'm not sure if he was able to. Dr. Lewis.
Hi. Dr. Lewis. Hi. I think it might help if we thought about what we were asking the HIE to do. I think of facilitation or a good faith effort as each of them being in the context of here's the information we have, here's where it came from, here are the here are ways to contact the organization or individual that sent us that information originally. So I think the intent of either word, of either concept is appropriate and valid, but it would be interesting to hear some discussion about what the expectations of the HIE are would be. Craig might have some comments also.
Thank you, Doctor.
Thank you, Doctor.
We have a couple. So, Dr. Lewis, we're going. That should take care of it. So let's. Craig, do you want to respond, and then we'll get to Mike and Kim?
Sure. I think I was going to agree with Catherine and Dr. Lewis that the HIE can't really facilitate the amendment of the records. Any record that the consumer received through CRISP would indicate where it came from, but it's ultimately up to the providers, the senders of the records, to amend them in their home systems.
Okay, good point. Kimberly and then Mike.
Yeah, I mean, I think if we read this, it says they shall facilitate in accordance with D4. And if we look at D4, that delineates what's expected of the HIE in this space. And as Dr. Lewis just pointed out, I mean, if these are things that can be done. It's an articulated list of what the HIE should do. So I don't think, I mean, I think it's all doable. I mean, it's not about accountability per se, other than if they're doing these things, they're accountable for doing these things, not necessarily accountable for ultimately if the provider amends the record. So.
Okay.
So assuming everyone agrees that D4 is doable, I mean, it's been there a long time. Then I'm not sure I understand why there's a problem with make a good faith effort if they have to facilitate by doing what's in D4.
Yeah, and I think some are saying it's repetitive. So, Mike, what are you? I know you hand up. What are your thoughts?
Well, I was going to basically align with much of the dialogue here. HIPAA privacy does allow a patient to request an amendment to their record if they believe it's inaccurate, but that law is directed towards health plans and providers being the designated record set originator. I'm not sure if HIE wants to take on that role of being a designated record set administrator.
Right. So we're going to get to Dr. Suarez and Pamela again. But Alana, can you just put a note here in this box to look closely at D? I think we said D4 or 4 rather, because we don't want it to be repetitive. I think Adrian brought up the notion of we could be being repetitive unnecessarily. So, Dr. Suarez.
Yeah, no, I totally agree with that. The only concern I have is that, yes, there is data that the providers have and the health plans have as part of their designated record set, and under HIPAA, they have their responsibility to allow consumers to request an amendment. But what about data that is not on the provider or the health plan, but actually on the HIE database that the patient has provided or the HIE has collected from the patient, and is not on a designated record set in a covered entity? So the HIE has some, I presume, primary data and are the primary source. That's not a designated record set, because it's not, HIEs are not really, unless they are, business associates, are not really covered entities. So I think the HIE has also a responsibility to offer an amendment process to consumers if the HIE has primary data with them that they have collected from the consumer and that does not exist or was not provided by a provider or a health plan.
Interesting. Okay. I think Lana is capturing that in the comment box. So it's patient generated. It could be patient generated health data you're talking about that the consumer may want to And HIE may be able to push it to their providers if the consumer says, here you go. I think that's what you're saying.
Yeah, it's data either provided by the consumer or collected by the HIE from the consumer directly. I'm not, I mean, I don't know exactly examples, but I presume that there are going to be instances where the HIE will receive data directly from the consumer. And that data, you know, the HIE might not know what the source was. So it has to declare it, you know, patient provided information, unless it has some traceability that points to this is data that existed originally in XYZ provider. But there is going to be data, and actually language in TEFCA, for example, notes this type of situation. So I think it might be helpful to look into TEFCA. I think I mentioned TEFCA before, but I think it's going to be worth looking at the provision of TEFCA, whether it's requirements on QHINs or requirements on participating organizations.
Mm-hmm. Yep, good point. Pamela.
So I was just going to say, there are some changes to D4 that I have some concerns with. So I think like going back to removing good faith effort could impact the new obligations placed on the HIE that have been added to D4. So it's hard to sort of discuss it without discussing the changes to D4. So it might be worth putting a pin on it until we've worked through those changes.
Understood. So Alana, if you could just mark this to come back to, let's get to D4 when it comes up, and then talk about it. So there's been some strike-throughs. I think can you scroll up a little bit there? Okay, scroll down a little bit because there's A, B, and C that are strike-throughs. Let's give everyone a moment or two to take a look and see if they have any concerns about the strike-throughs. Many days of proceeding. Anyone have any concerns about? I mean, it seems reasonable to take this out, but I'd be interested to hear if there's any thoughts or opposition to that. Emily.
It looks like most of this is just moved to D4. Isn't this? I mean, this language looks essentially what is in D4 now. I'm sorry. Yeah, D4 and then modified.
Okay.
Right.
I can't.
Agree. Yes.
Okay. All right. Let's scroll down. Let's go to D4 and then back up. Would that be? And anyone doesn't have any opposition, let's do that because in order to keep the continuity of thoughts. Okay, HIE. Okay, an HIE shall make good faith efforts. So we've taken that out. An HIE shall provide information to consumers regarding how the healthcare consumer must notify the HIE. Pamela, your thoughts?
I don't understand that addition. The HIE shall provide information to the consumer regarding how the healthcare consumer must notify the HIE of their desire to amend the patient's health information available through the HIE.
Yeah, it almost gets back to that notice of privacy practice. It's if you're at the beginning stage, you tell the consumers if they want to make changes, here's how you do it. That's what it feels like to me, but I don't want to presuppose.
I think it's the must that's confusing me. Like, is there some obligation on a healthcare consumer now to notify an HIE of their desire to amend the record? I don't understand the must.
That's a good point.
Is it can? Is it may? I mean, is that the right?
It does feel like a must or shall doesn't fit well here.
Well, it can notify. I think.
Yeah. Let's see. I think Mike was going to provide us some as well. Mike, your thoughts?
Well, I'm just wondering around, how an HIE is going to also validate that that request is actually valid, and that if it is part of a designated record set, that that originator is somehow notified and agrees that the record on file within the HIE is inaccurate and does need to be corrected.
Yeah, that's definitely a good point. HIEs must can. So does this really maybe the bigger question is, does A really get us anything? I mean, are we? I'm just sort of puzzled for a moment. Going, does it create value in terms of the process or policies? I mean, do we need to call it out specifically at all? I'd be curious, Pamela.
I mean, I guess my thought here is the providers have an obligation to tell the patients how to request an amendment. We all know that nobody reads that and pays attention to it. So do we really need to add another obligation on HIEs to sort of do the same thing? It doesn't seem like it adds anything. Again, you're already educating your consumers on how to request amendments directly from consumers.
Yeah.
I mean, someone might see differently.
Let's bring in a couple of our consumer friends. Robin, your thoughts?
So I think generally at each point we can provide the consumer information. I think it's positive. I do agree that sometimes consumers, there's too much information and they can't pay attention to everything, which I think makes it doubly important to take at every opportunity there could be consumer education to do that.
Pamela, response?
I guess the question I have is, how would they? So let's say that, so again, if we're talking about, there isn't a lot of direct to consumer, and we'll get to that section later, but direct to consumer education by the HIEs. So this feels like an obligation for the HIE to educate consumers on how to request amendments to the HIE, but I don't know, if not through the provider or the participating organizations, how the HIEs reach the consumers. So is this just like on their website? That's my concern, is so much of the HIE education comes through the participating providers. And so I don't know if placing independent obligations on the HIEs gets us farther, since the relationship is so much between the patient and the provider.
So now there's a couple, that's a great point. There's a couple of others that want to weigh in that I want to ask, but would it be, maybe Pamela, to your point, and thinking about what Robin said, is it, if an HIE makes this information available, it shall be posted on, or must be posted on the web page, something like that? It's more of, if you do it, here's the guidance. How does that feel? I think, Pamela?
And I think even having a requirement that it be on their website, I think is perfectly fine. I just think it needs to be clear how they're supposed to notify their consumers, because I think that can get very, and again, it dovetails to the discussion of patient education that's going to come later, but I want to bring it up here, which is HIEs don't have that same direct relationship with patients. And so I want to be mindful of making sure we're all on the same page as to how HIEs will educate patients on these issues.
Yeah, so let's just put a note that I think it does come up under the consumer education, but also here, Alana, maybe we just note for a moment if HIEs do this, there's some structure around process, and I think that's what we're hearing a little bit. We can make the condition. So Rob, can you just state your thought for us here?
Yeah, sure. Kind of going back to what Craig said, is like, most HIEs, at least that I'm familiar with in Maryland, don't actually collect patient generated data. Like if CRISP were collecting, PHR, like personal health record data from consumers and storing it, then yeah, I can see, they would need to provide a way to modify that. But, and CRISP may do that someday. I don't know if that's on the roadmap, but that's what I'm saying. Like, can we make it conditional? Like if an HIE is collecting that data to begin with, then these rules would apply. But if they're not, then it really shouldn't apply. Because like in all cases, like if the HIE is going to refer them back to the hospital or physician practice or whoever the provider organization is to modify that data.
Yeah, I think you're making a good point, and I think Alana, you're sort of noting in the comments it's more of a if you do, then there's a process, as opposed to what the point Pamela's making is the must. I do think the interesting point about the takeaway here, one of the takeaways to note is that the comment, Rob, you made is that as patient-generated health data becomes more of a norm, HIEs may begin to offer these kinds of services. So I think if we think long-term or visionary, they're having some kind of guardrails to your point of air quotes, if it's probably advisable. Yeah. And Mike, were you going to make a comment here as well? I couldn't tell.
No, I was not done.
Okay, very good. Catherine, your thoughts?
Yeah, Dave, and reflecting on this, I think this is supposed to be forward thinking, right? That is kind of directionally where we are. And I think that resolves that word must, right? Because if you read down and kind of digest what is below that, we are saying the consumer must notify the HIE using the means in which they articulate they need to be notified. And they must use that notification format in order for the HIE to respond with the said points below, right? The said actions below. And if you try to tie that back to the historical intent, but still have sort of the lens looking forward, I think we were trying to create another point in the exchanging of information, even if it were not designated HIE data, if you will. It was provider data. It was not intended to be a middle person in that, but yet another safety net, if you will, for the consumer, right? To have an avenue to do so. But the forward-thinking lens, I really agree, makes a lot of sense. I think we maybe need to digest this more and fine-tune it. But I think the concept makes sense of if there is some, HIE designated record set, yeah, we should tell consumers how they need to respond to an HIE, and the HIE should have outlined what they need to do to, in accordance, respond to that request from a consumer.
Makes sense. Thank you. Michelle, are you, I know you were planning to step away briefly. Are you still available?
I'm here, yes.
What are your thoughts?
Oh boy. Let me bring up the big screen. Put it up on the big board. Hold on just one second. I'm trying to also align to what Hans was saying. Yeah, I think though that's a pretty straightforward one. Many health information. Golly, sorry, hang on just one second, please.
No worries.
And so is this specifically with regards to modifying what's in the HIE and the HIE driving that, or is it simply just making sure that the organizations that are providing data have a clear understanding of how to amend the information?
Well, I think that's a great point, Michelle. I think what we were trying to say is that the way it appeared is that it was putting the onus on HIEs to do something. And I think what we're hearing is that direct-to-consumer relationship by an HIE doesn't really exist in most circumstances. So where I think we landed was it's more of a, if an HIE is in that kind of space where it is getting data from a consumer, then they should tell them directly. However, if they want to tell consumers, there should be structure around, they would like to do that, how that information gets communicated. It will come up again in the patient education section, so maybe that would be an opportunity to peel this onion a bit more. So thank you, Michelle. Kimberly, your thoughts? And then Dr. Suarez.
Yeah, I mean, I'm looking at. I think I agree with a lot of people that is it 43A? No, 4A. The A is probably unnecessary because 4 says the HIE shall facilitate healthcare consumers amendment, right? Through the HIE by telling them how to seek amendment of that information. And then B says within a certain period of time, they have to tell them who to contact to change their information. It has to be consistent with the Health General article. And then sort of the meat of it, where the HIEs really get involved, is to the extent that we've got inaccurate information in the HIE that's been pushed out. And I know I'm not using the right words, but right, I mean, that information has been sent out, right? The obligation then is to ensure that anyone it was sent out to now knows that information upon which they've previously relied or incorporated somehow, and I don't understand the technology, is inaccurate and has been amended, right? So I don't know that A is necessary. It's, hey, I can potentially see a consumer, I don't know, talking to a provider about an issue and the consumer saying, well, the provider saying, I don't know, an example might be, I got information that you have a drug addiction, and that person could say, well, where did you get that information? I don't have a drug addiction. Well, it was on the from the HIE, from CRISP, whatever. What? That's what that patient's going to CRISP and figuring out, how do I fix this? Because this isn't right. And how do I make sure that that change gets pushed out all along, right? And that's what this was intended to address. So I agree with many of you that A isn't necessary, but I still think the rest is important.
Good point. Pamela.
Yeah, I mean, I agree with that. I think A was really what I had a big issue with. I'm curious about, and maybe Craig can chime in and others on the practicability of providing each organization with the amended information. I mean, I don't know how that works in terms of, to Kim's point, like pushing and pulling and things. Like, that could be, I just would like to understand that better, because I feel like that could be a very challenging activity. And I just, especially if how does the HIE find out about it? I just don't know how it works. So would like to hear more about that.
So Craig, your thoughts, and then Dr. Suarez will come to you.
Yeah, I mean, that's exactly my concern. Like, if I think through kind of how this would normally happen or how this happens today, right? I'm a patient. I'm at my doctor's office, and they say, it says here you have a drug addiction. And I say, oh my gosh, that's not right. I either say, how do you know that? And they say, it's through CRISP, and it looks like Johns Hopkins wrote it down. And I went to Johns Hopkins 2 months ago. That's weird. Let me call my doctor. And so they kind of connect the dots themselves in real time. Or they call CRISP and they say, someone submitted false information. There's no ability for the consumer to directly view the information in CRISP today. So they would ask for an accounting of disclosures, and we would tell them, essentially, folks who have accessed their records, and give them kind of the background there. And presumably they could then work through, okay, well, let me go back to Johns Hopkins, because I was there a couple months ago, and call that facility. I don't disagree with the fact that, all HIEs could put up on their website, this is how records get into the HIE. This is how best to amend them. We recommend you call your provider. Like, there's probably some general consumer guidance that I think is appropriate. But then when records are amended, right, the data is pushed through the HIE channels and added to the records. Often that's an overwrite, but there's not I think a technical way to broadly distribute the fact that something's been updated. I just don't see that being possible.
Yeah. Okay. That's a good point. Dr. Suarez.
Well, I've been listening to all this conversation. I really think A is not necessary, and I agree with that with others, because it's already written in B how the consumer is supposed to communicate. It says receiving a notice electronically or written, or receiving it by mail. And so it's already explaining that the HIE might get a request from a consumer to amend a record, and they will likely receive it via electronic mean or via a mail, or, and so this first paragraph, A, is not adding anything really, the way I see it. The other thing I think is important is this other point about all this is centered around the HIE only receives data from covered entities, and the locus of the designated record set is in there. And again, I emphasize and I note that there are HIEs that are collecting data and maintaining data about the consumer directly from the consumer. And again, TEFCA talks about this. And then, so I agree that there needs to be another statement about if the HIE collects data themselves from the consumer and is the custodial of that data, let's call it that way or whatever, then there has to be a process by which that data that is now in the hands of the HIE and the consumer wants to amend can be amended. And that is not the responsibility of a cover entity that has a separate designated record set. So I think that statement is not in here anywhere, as I see it. So I would emphasize the need to include something like that in case and in the instances when HIEs have their own data, collect their own data from the consumer, receive data from the consumer, and are going to be responsible for maintaining that data and updating it with amended data.
Yeah, and I think that's what we hear is that we're hearing is essentially that B could take the place of A as it exists today, but A should be tweaked. It says along the lines of if you collect this information, as opposed to anything other than that. Is that fair to say? And since Pamela raised this to begin with, I'm going to come back to her, and then maybe we can push forward. Pamela, does it make sense to say essentially if you're doing it, here's some structure as opposed to you have to do this?
Right. If you're collecting consumer information, then you have to provide education as to how they can amend that information that you collect, essentially.
Yes.
Yes, that makes perfect sense to me.
I think we can add that, make that clear, Alana, in our comments, and then we can press forward a little bit. We're making progress. The conversation has been really good, so thank you all. So let's look at the new 5. The addition here of, which includes information on HEPA request. Pamela.
I'm sorry, but did we resolve D? Provide each organization with the amended information? I got kicked off for a second, so I didn't know if that was what Craig was describing, that it would be incredibly difficult to actually push the information out to those. It's obviously overrides and is available, so any new queries would happen, but I don't know if it's technically possible to push it out to all people who have looked at it before.
Yeah, so scroll down just a little bit, Alana, because it's not on view for everyone.
Yeah, I mean, today, because it's good faith effort, someone's notified when they look in the system and see that data has been updated or changed or amended. I do think we need some flexibility. Either it's because it's a good faith effort, or maybe there's not a notification. Maybe it's just the amended information is provided when they query, but I think we need some space there to give it to the groups as they request it, not to push it ahead of time.
So,
sorry, David, do you mind if I just add something there?
No worries, please proceed.
Okay, so I wonder if it's worth considering what the urgency is to communicating when there are changes. So, for example, if it's a modification to a clinical note, does that really warrant a proactive notification, for example, or is it really just making sure that the provider is always checking for the most recent information versus something that may cause and basically patient harm, such as excluding an allergy, for example, that could cause anaphylactic shock or something, and maybe the approach should be different depending on what the data could be.
Yeah, thank you. That's a great point. And Kim, before we bring you in, I just want to call everyone's attention back to a comment Dr. Lewis made in the other section, which was facilitate can be interpreted to mean different things, where the HIE can, try to do a connection, and it may work, it may not work, which is somewhat the underlying meaning of good faith in one of the views Dr. Lewis raised. But facilitate can also mean, it gets back to a comment that Pamela made, must do. And is that really what we are aspiring to achieve? So, Kimberly, what are your thoughts?
So, I'm still really struck with this notion that we're talking about a computerized system that can look to see, this particular misinformation's been pushed out. I don't know how a computer can't identify that and then push out a notice that there's been a change to information that was previously accessed, particularly if it's something where there could be patient harm. But in any event, the current regs when a consumer, and on my unit, we help people amend their records frequently in my office. So this is not an uncommon occurrence where there's a problem with the record. And the current regulations, when you go directly to the provider who has the incorrect record, require that provider to give notice of the change in the medical record to any individual the person in interest has designated to receive that change notice, and to anyone to whom that provider has disclosed inaccurate or incomplete record within the previous 6 months. So if the provider is supposed to push that out, and they notify, the HIE, for example, I suppose one possibility is we could seek to change the law to require the HIE to give the list to the provider of everybody that got that improper information and put it on the provider. But I would think that the HIE, I'm not sure I understand where the technical ability it would be lacking here.
So Craig, I'm going to bring you in just a moment, but let's get to respond to Kimberly's comment, but let's get Dr. Suarez and Adrian comments.
Thank you, because I think the issue is exactly that. For the HIE to be able to provide the amended information, the HIE must first receive it from the entity, provider, cover entity, whoever that hold that information as part of the designated record set and agree to make the amendment. So in the process, as I think Kimberly was explaining, providers, we all the time get requests for amendments. We make the appropriate amendments when they are confirmed, and then in order for the HIE to know that the amendment has been made, they need to, and be able to push that out, they need to receive it first. So I think this creates a bit of a challenge for the HIE to notify and push the amended data unless they receive it. And it's not clear whether they will be one that will be receiving it. If the provider makes amendment and makes a submission to other providers that have received the data, the HIE might not be one of the entities that receive that amended data.
Yeah, and so Alana, can you just note for D that we need to do more work on this make a good faith effort component piece? We are nearing the conclusion of our time today, and I don't want us to lose track of that. Adrian, your thoughts, and then Craig, and then we'll break. Adrian, I don't know if you still have a comment here, or maybe you're still. Okay. Craig, your reaction.
Yeah, I think Adrian was probably going to speak to some of the technical limitations. I think Kim's asking really, really important and thoughtful questions. So Adrian, if you do get on, jump in. But I would say, because we aren't the designated record holder, and because there's a gap between the patient and us, it's really hard, or it's nearly impossible for the technology to kind of be collecting millions of messages per day and understand which of those messages is an overwrite because a John Doe got a name applied in the ED versus an updated name versus an updated clinical diagnosis from a provider versus a patient stating something was inaccurate. And kind of when you go through all those machinations of kind of what things being updated was accessed by whom and how do you push it out, it just, I can't think of an algorithm that would allow it to do it well. And then you add on the fact, what if the patient opted out when they updated their record? Then I no longer can tell the prior providers of the new information because the patient's opted out, so I can't share it. Or what if the patient no longer has a treatment relationship because they haven't been to the site in the period of time that would designate that? Like, there's just a lot there. And I think not having the direct consumer interaction really makes the HIE different from other providers.
Yeah, I think we need to do some more work on this particular item. I think we're hearing a couple scenarios. One is it's not needed because it's really addressed in the next, as you go down the list. The other is it's just an option that provides, says, if you're going to do this, then here's some structure. And I think that's the piece we want to consider a bit more. I definitely think all the comments are very relevant, and I think this is one that we need to think about, and we can consult a bit more with our friends from Post and Shell on getting their thoughts between now and our next meeting. And we might be able to start here by coming back with some ideas. So we are at 1 minute before the end of our time commitment for today. We try to be mindful of everybody's time. It's very valuable to us. And so we try not to run over and do our best not to do that. So are there any closing remarks, Alana, that need to be made at this point?
I think just as you said, David, we'll revisit the comments we received this afternoon. And we did want to let folks know that we tentatively have a meeting date for December 9th, same time, and we'll be sending out additional information about that next meeting.
And we'll try to get that out early next week. So, because we know December fills up, it's a busy month for many of you. I can't say it enough how much we appreciate your willingness to stay engaged with us on this. I think what you're hearing is clearly we can't do this without you. And I make that plea because there aren't any better experts than the group that I'm looking at here, all 30 plus. Everyone brings a valuable perspective that is going to make these regulations very tenable as we go into the future. So thank you. We give you, from the MHCC's perspective, a huge round of applause, and hope we can keep you engaged as we continue onward. With that, I'll bid you all a wonderful evening and a great afternoon, and hopefully a terrific weekend. So enjoy, and we look forward to talking with you again soon. Thank you. Bye, everybody.
Thank you. Y'all take care.
Yeah.